This video is the last of a 3-video series on the discussion of bleeding in early pregnancy. In the previous videos, I have discussed implantation bleed, ectopic pregnancy, and miscarriage. And in this video, we are going to be talking about molar pregnancy. Okay, so molar pregnancy is sometimes referred to as gestational trophoblastic disease. And this is basically a problem with the placenta, where there is excessive proliferation of trophoblastic tissue. A quick recap now to embryology on trophoblasts. So these are the cells that form the outer layer of the blastocyst, which is formed day 4 post-fertilization. They provide nutrients to the embryo and will form the major part of the placenta. Okay, so most of the time a molar pregnancy occurs because of a chromosomal abnormality of the trophoblastic tissue. In the UK, molar pregnancy occurs in 1 to 3 per 1,000 pregnancies. So, as we said before, molar pregnancy is due to an excessive proliferation of trophoblastic tissue. When this happens, HCG levels are very high because of excessive secretion by the trophoblastic tissue. Now, this proliferation can be either localized and non-invasive, where it is referred to as a hydatidiform mole, or it can be invasive, resembling malignant tissue. And we shall be looking at these two types in turn. Okay, so we're going to talk about the hydatidiform mole first, which we said is the non-invasive form. So this can be divided into two, the complete mole and the partial mole. Complete mole most commonly occurs when an empty ovum is fertilized by one sperm, and this occurs in 90% of cases. The chromosomes will duplicate and give a karyotype of 46XX. Sometimes a complete mole occurs when an empty ovum is fertilized by two sperm, giving a karyotype of 46XX or 46XY. On the other hand, a partial mole occurs when an ovum is fertilized by two sperm. This will give a karyotype of 69XXY, 69XXX, and 69XYY. So, a complete mole is genetically diploid, while a partial mole is genetically triploid. In a complete mole, the karyotype is paternally derived, as all chromosomes are coming from the sperm, so coming from the father, while in a partial mole, the chromosomes are derived from both parents. In a complete mole, there is no fetal tissue, but there is a proliferation of swollen chorionic villi, which is described to resemble a bunch of grapes. In a partial mole, there is variable evidence of a fetus. Now, 15% of complete moles will progress to gestational trophoblastic neoplasia, GTN, while 0.5% of partial moles will progress to GTN. But what is GTN? So, GTN is gestational trophoblastic neoplasia, which refers to the invasive types of gestational trophoblastic disease we mentioned previously. And over here, the HCG level remains persistently high. We've got different types of GTN. The invasive mole, where the invasion is limited to the uterus. Choriocarcinoma, where invasion goes beyond the uterus and can metastasize, classically to the lungs. Choriocarcinoma can develop from the following. So we've got molar pregnancy, 50%, miscarriage, 25%, normal pregnancy, 22%, and ectopic pregnancy, 3%. We've also got the placental site tumor, which is very rare and arises from intermediate trophoblast. Good, so next moving on to the risk factors for a molar pregnancy. These include a previous molar pregnancy, extremes of reproductive age, and Asian ethnicity. So, presentation now. Patients with a molar pregnancy might present with bleeding PV. They may present with an enlarged uterus due to the rapid growth of the mole. They might also present with ovarian cysts, which are secondary to the high levels of HCG. And these might actually become quite large, which cause abdominal swelling. They might even result in torsion of the ovary, as the ovary will twist on itself, restricting its blood supply, and the patient will present in severe pain and might need surgery to remove the cyst. Patients with a molar pregnancy also classically present with nausea and vomiting because of the high HCG levels, And they can also present with pre-eclampsia. A side note here on pre-eclampsia, this is basically a disorder of pregnancy with high blood pressure, which can result to damage to other organs such as kidneys, liver, brain, etc. These patients can present with headaches, blurring of vision, epigastric pain, and swelling. In a normal pregnancy, they would present after 20 weeks of pregnancy. However, if preeclampsia occurs earlier in the pregnancy, it might be a sign of a molar pregnancy. Lastly, they can also present with hyperthyroidism. This is because of the similar structures of HCG and TSH. Therefore, the high HCG levels will mimic TSH and drive the body into a hyperthyroid state. So these patients will present with tachycardia, sweating, problems tolerating heat, mild tremors, and other symptoms. Good, so how do we investigate these patients now? So, of course, we've been rambling on about HCG, so we always take a beta HCG level, which will be high. An ultrasound is also important. Classically, a snowstorm appearance can be identified on ultrasound when scanning a complete mole. So, when a molar pregnancy is confirmed, we need to treat these patients with an ERPC, an evacuation of retained products of conception. All of these patients will require follow-up with seared HCGs because we want to check for those patients which will remain with a persistently high HCG level, where we will make a diagnosis of GTN, gestational trophoblastic neoplasia. These patients will now require chemotherapy. Great. So we also need to counsel these patients properly. We need to tell them to avoid getting pregnant for the next 3 months, that they cannot take the contraceptive pill or hormone replacement therapy, that a molar pregnancy might recur in a future pregnancy. So we must take histology after every pregnancy to check for recurrence. I hope this was helpful. Thank you.